Okay, welcome. Bienvenue to the College of Rehabilitation Sciences Illuminate presentation for September 2021. Our event is being held on Treaty 1 territory. This is territory that has been inhabited by Indigenous peoples from the beginning. We recognize the contributions of the Anishinaabe, Cree, Oji-Cree, Dakota, Dene, Métis, and other Indigenous peoples in caring for this land and in shaping and strengthening this community. Taking a moment to acknowledge our true history that occurred on this land and the harms of the past and the present allows all of us who live, play, and work here to collectively recommit to working together to address the calls to action of the Truth and Reconciliation Commission and the calls to justice for murdered and missing Indigenous women and girls. And today we can commit to addressing health inequities that have widened even further for Indigenous peoples due to the layering of COVID-19 on top of inequitable health and social structures. And so today I'm very pleased to welcome Dana Kliewer, Marlee Mayer, and Katie Kitchen to present to us today on long COVID, on the ground, real-time evidence and lived experience. As researchers work to understand this condition, clinicians and clients have had to address it with minimal empirical evidence for guidance. Dana, Marlee, and Katie have intimate knowledge of the condition, and they are and have been and continue to be fierce advocates for rehabilitation services for long COVID in Manitoba. Thank you so much, Dana, Marlee, and Katie, for coming to share your knowledge about long COVID and rehabilitation today. And I'll turn it over to you.
Thanks, Kara. So like Kara said, the three of us are here this afternoon to present what we've learned on the ground with COVID. So in the way of disclosures, I want to disclose first and foremost that I am a voluntary participant in this presentation. I continue to be an active patient of the pulmonary rehab program at Deer Lodge Center, and I have received numerous diagnostic testing through WRHA facilities. I have provided my consent to my treatment providers, which at times have included both Marlee and Dana, to share my personal health information as relevant to this presentation today. So we have three main learning objectives this afternoon. The first is to describe post-COVID condition using emerging literature, as well as lived and clinical experiences. The second is to compare local and global evidence of post-COVID prevalence, symptoms, and rehabilitation approaches. And third is to discuss the importance of multidisciplinary care for the post-COVID condition. So we wanted to start with this quote by Montani and colleagues. If we are to learn from the positive aspects of this dramatic episode, we will keep in mind the solidarity and adaptability of healthcare teams and the need to break down the walls between medical specialties to optimize the management of patients with post-acute COVID-19 syndrome. So I am a practicing occupational therapist, but today I'm actually here not in that capacity and instead to share my real life experience. So at present, I am a 34-year-old female. I have no underlying health conditions. I have no family history of asthma or respiratory disorders. I was very physically fit, no drug or alcohol use, work full-time as a frontline healthcare employee, also the sole proprietor of an independent small business, some of which you can see in my kind of backdrop here. No known exposures to COVID, and no breaches in my personal protective equipment. So if we go back about 9 months, all the way back to December 7th, 2020, I started my day as I usually did. I woke up at 5:30 in the morning. I exercised in my home gym that my husband and I had created. And then I went to work and worked at the office site all day. Around 8:00 p.m., I developed very localized, really sharp chest pain, kind of right at in my midline area near my sternum. My first thought was, oh, maybe it's costochondritis, which sounds like a weird thing to know about, but that was my first instinct, is maybe it was some sort of rib injury that I'd sustained, perhaps from my workout. So I went to bed. I continued to have that chest pain overnight. My sleep was disrupted. It hurt to kind of do different movements. And so when I woke up in the morning, I completed my employer self-screening, as I did every day. And when I sort of honestly answered the questions, I failed on one single question, and that was it hurt to take a deep breath. So at that point, I wasn't limited in my ability to take a deep breath, but it hurt. So I thought, well, if I'm really being a stickler here, I don't pass this. And so it was on that lone symptom that I went for a COVID test the morning of December 8th. So December 8th and 9th, this was sort of at the peak of the second wave, so the test took a while to come back. I continued to have very localized chest pain. Deep breaths were increasingly difficult, but I was able to work remotely each day. I was seen via Microsoft Teams, much like this, by numerous colleagues, all of whom remarked that I looked well. So on the morning of December 10th, this is a screenshot from my phone. You can see the time in the top left there of 7:17 a.m. because of course, when one is waiting a COVID test, one checks the database at all hours of the day and night. So imagine my surprise when I woke up to find this screen. I think many of us at this point now have been tested for COVID. Many people, luckily, don't have the experience of seeing this positive test result. So many things ran through my mind. First of all, not costochondritis. So I guess that was the silver lining. I did feel tremendous shame about this diagnosis. I felt very fearful of what was to come. I felt concerned and worried for my colleagues and my patients as I'd been in that office space, certainly when I had the virus within me. And then you automatically start thinking about what do I need to do? So I notified my colleagues, I determined my close contacts, I made endless phone calls with, severe chest pain, and was eventually actually told to go to a hospital with an ICU. And that's a direct quote from Occupational Health and Safety. So at their direction, I did on December 10th go to St. Boniface Hospital emergency room. I didn't require an admission and I was discharged home. So December 10th to 18th, this was kind of my view. This is the ceiling in my bedroom as I isolated at home. So I never lost my senses of taste or smell. I never had a sore throat, didn't have any gastro symptoms, but I did continue to have severe shortness of breath, and that certainly got worse throughout that period of time. My brother overnighted me on a finger oxygen meter, and my oxygen levels were pretty consistently between 92 and 99%, despite that severe shortness of breath. So I continued to have really severe chest pain, no endurance. My sleep was really disrupted. I would sort of wake up gasping for breath. And I continued to have numerous phone calls with OSH and with public health. It's also worth noting that my husband tested negative twice. So as of December 18th, I was deemed recovered, which is very misleading and in fact, inaccurate terminology. So at this point, my quarantine was finished. You're then faced with, now what? I expected, as I think my medical team did, that I would return very quickly to my level of baseline function and my baseline health. On January 4th, I made the decision to return to work on a modified work schedule. Our team has been working from home on a rotational basis for the last sort of year and a half, and that was really helpful and probably the only reason I was able to return to work when I did. That being said, I have wondered if that was perhaps too soon, as even when I returned, I had significant symptoms, though I was non-infectious. I did submit for a workers' compensation board claim, and after some advocacy was accepted into that program. Shortly thereafter, I was referred to the post-COVID clinic by my family physician. On March 8th, I had my first appointment with the post-COVID clinic, which was at Health Sciences Center. And it was through that clinic that I was subsequently referred to the pulmonary rehab program at Deer Lodge. I luckily got in on a cancellation list and had my first appointment with the pulmonary rehab program at May 3rd. So from that point on, I've had more medical tests than I've ever had in my life. So these are the ones I can remember. So I've had 2 chest x-rays. I've had, I don't know, what feels like liters of blood drawn from me. I've had a CT of my chest. I've had 2 nuclear medicine tests. Those include the VQ perfusion scan, as well as the MUGA test. I've completed 2 6-minute walk tests. And I've also undergone Holter monitor testing, as well as pulmonary function tests. And that was just a couple of weeks ago. So what did all this tell us about me? Not much. The chest x-ray was clear. The CT of my chest was grossly normal, though it was ordered with the wrong contrast. The VQ perfusion scan, interestingly, showed no clots, but did show some what they described as heterogeneity of perfusion noted. But they also noted that that should be considered essentially normal. My MUGA demonstrated over 70% ejection fraction. My 6-minute walk test did demonstrate a normal oxygen level. However, I did have a reduced performance on that measure. My blood work has also been grossly normal. I did have some slight results over time, one of which was that my anti-nuclear antibody, ANA, was initially positive. It's since returned to being negative, also demonstrating enlarged platelets and an elevated white blood count. So I fall into the group of people who have long COVID. So as the COVID virus continued to infect more and more people, its nefarious relative, long COVID, emerged. So initially, COVID was touted as this sort of short-lived illness, primarily affecting older adults or those who had sort of numerous medical comorbidities. I think for these reasons, the notion of long COVID was slow to be recognized. However, as more people became ill with the virus, we began hearing more and more about this long COVID, sort of this mysterious post-acute syndrome that people had months after their infection. So more specifically, these were people who tested positive for COVID, or for many, likely had COVID before testing was widely available. So long COVID is broadly defined as effects of COVID that persist for more than 12 weeks after you've tested positive rather for COVID. So long COVID is also called post-acute COVID-19 syndrome, or post-acute sequelae of SARS-CoV-2, or long haulers. So each of these terms make sort of no assumptions regarding etiology or prognosis, but simply imply that the symptoms of COVID have not yet resolved. So locally, a Shared Health spokesperson spoke with CBC News in June 2021, and at that point stated that there was more than 12,000 people in Manitoba who have experienced or were presently experiencing long COVID. At that time, that represented about 22% of all cases within Manitoba. This number has likely risen in the last few months as more and more people have been exposed to the virus and others who have now passed sort of that 12-week post-infection mark. So globally, it's estimated that 10% of individuals with COVID go on to develop persistent symptoms beyond that 12-week period. And in the UK, it's estimated that there are over 1 million people who are experiencing post-COVID syndrome. Other countries have not released specific prevalence estimates, and there's a variety of challenges in gathering this information. So this is a screenshot on the left here of a Canadian group that was developed by a 53-year-old female from Oakville, Ontario, who had COVID in March 2020 and went on to develop long COVID. So she developed this group when many Canadians were having persistent symptoms past their initial infections, and to offer support for those who were likely infected by COVID before the tests were widely available. So over the past year and a half, this group has grown to include over 14,000 members. You can see in the screenshot here, when I took it, it was 14.1 thousand. And over time, this term of long COVID developed traction kind of within the larger community. It's important to recognize that the notion of long COVID first emerged by people who found each other through social media. And people sort of began describing, in the absence of sort of biomedical knowledge or even medical legitimacy at times, their experiences, and campaigns to raise awareness, influence guidelines and service models, and contribute to research. The two articles that we've posted the titles of on the right provide excellent context of how long COVID emerged. So I found the second article by Rushforth and colleagues to be particularly impactful, and it really validated much of the experiences that I had had. And each of these articles are contained within our reference list. So I'm now going to pass it over to Dana to discuss pulmonary rehab.
Thank you very much, Katie, for sharing your important story. As Katie said, my name is Dana. I'm a physiotherapist in the pulmonary rehabilitation program at Deer Lodge Center. Unlike Katie, I'm not an expert in the experience of long COVID, and I want to preface my portion here in saying that, I have no expertise in this. But I do know something about pulmonary rehab, and Katie's already mentioned her involvement in pulmonary rehab. And so I feel it's important to describe the context of PR as I begin to tell you my clinical journey in working with clients with long COVID. So pulmonary rehab is a robust evidence-based treatment intervention for individuals with chronic lung conditions. I like to say it's as close as to proven science you can get in a rehab realm. It has a specific outcome framework, including measuring improvements in quality of life, symptom management, exercise tolerance for individuals. Mainly with COPD are the individuals we see in pulmonary rehab. And as you can see here, it's part of the stepwise evidence-based approach according to global and Canadian thoracic guidelines. We have 3 program sites in Winnipeg, so the audience may not know out there. Deer Lodge is one of them, Misericordia Health Center, and my colleagues at the Wellness Institute at Seven Oaks. We are an outpatient program, and like I said, we are mainly seeing 80% COPD, also pulmonary fibrosis, and our average age of our clients are about age 50 and older. So I just want to take you through a little bit of a timeline here. It was about late 2020 when Manitoba was experiencing its second wave of the pandemic that we met regionally as a program with leadership to prepare criteria to accept post-COVID clients. Anticipating, and I'll talk for myself personally here as a clinician, I had certain expectations when considering the pandemic and what kind of rehab clients we'd see. I anticipated pulmonary sequela, so interstitial lung disease, exertional desaturation, deconditioning. I also anticipated an uptick in our post-hospital referrals, as Katie already mentioned, likely those clients who are older in our age demographic. I didn't really expect a change in age, and likely those with other comorbid conditions, perhaps even those with pre-existing underlying lung conditions. So treating clients after severe pneumonia, either after COPD exacerbation, bronchiectasis exacerbation, or other viral illnesses such as H1N1 was not new to us in PR. But what we had to do was do a little bit of guesswork with changing our outcome measures and trying to, because we really had no outcome measure framework for this condition. Pulmonary rehab is largely a physical exercise-based intervention, and I didn't anticipate it deviating for that. I thought because of the robust evidence in PR, we were probably a good fit for long-term pulmonary sequela. As this picture shows, I quickly realized with our first couple referrals that my expectations floated away. So it was welcome to reality, and this was a post-COVID reality. So some of the realizations we quickly had as a team is that this was not just a respiratory system impact. We were seeing multi-system impairments, and with those multi-system impairments came significant activity limitations and significant participation restrictions for our clients. Clients were describing a plethora of symptoms: brain fog, chest pain, palpitations, breathing dysfunction, dyspnea, pain, myalgia, dizziness, headache, altered smell, you name it, it was there. With these, and as well, post-viral fatigue. Now, as working in chronic disease management, working with people with COPD and long chronic conditions, I thought I knew fatigue. I thought I knew how to teach clients how to manage their fatigue. Fatigue related to deconditioning, perhaps, fatigue related to increased work of breathing as it relates to our pulmonary clients. This was the biggest realization I had early on meeting our post-COVID referrals. I did not know fatigue. I did not know what I did not know about post-viral fatigue. This was a disproportionate fatigue, a highly unusual fatigue that people were describing in response to energy expenditure. And Marlee will talk a little bit more about this. This was not just a deconditioning process, and therefore a conditioning process would not work. Some other realizations: a large proportion of our clients were non-hospitalized or considered mild cases. And so it became evident quickly and early on that the level of disability that clients were experiencing seemed to be disproportionate to the initial illness severity. As well, many clients were younger, in their 30s. I think some of our other sites had people in their 20s, 18 years old, their 30s, 40s, 50s, people in prime working age. And as Kara mentioned in the introduction at the beginning, I very quickly realized I was dealing with something in real time with a very limited evidence base, of course. I had no idea what the natural recovery looked like for post-COVID. I had no idea whether my intervention was helping or harming the client, or whether it was even necessary. And I quickly realized I take for granted working with PR, which is an intervention that is highly evidence-based, where the intervention alone, if used correctly, has a clear framework for improved outcomes, which is why I do love working in PR. Needless to say, it was a real lesson in humility, taking a step back, and a firm acknowledgement that I didn't know what I was doing at that exact point in time. Luckily, I was not the only one that felt this way, and I soon read and listened to similar commentaries in PT journals. This commentary was from the Journal of Orthopedic and Sports Physiotherapy, of people who, academics, much smarter than I perhaps, who are having those exact same realizations. And I just want to highlight really quickly Dr. Simone DeCarey at the University of Sherbrooke. He's an academic physio. He does a wide variety of research in many areas, but his lab was one of the first to receive national funding at a point where, for rehabilitation in long COVID, at a point where all that money was going to, of course, therapeutics and vaccination. And it was interesting because he approached things from a pulmonary rehab framework because of the robust evidence and the expectations. And long story short, he ended up halting his study when the subject group started to emerge and he started to recruit on Facebook and everything like that. He really stopped his study, had to stop, listen, have those clinical conversations before proceeding with a study that could potentially do harm to the clients. And he ended up completely switching his protocol. To paraphrase his words, and I listened to a podcast on this, it's in the reference section with him, something wasn't right. PR alone or physio alone wasn't cutting it. And he started to realize the necessity of a multidisciplinary approach. So seeing this happen with experts at the same time I was, shortly before I was having to manage this locally, was somewhat reassuring. I want to just quickly show what our first two cases looked like in pulmonary rehab, so we can kind of juxtapose these. We have case one was a client in their 50s, 4-week ICU stay. He had acute respiratory distress syndrome, of course, abnormal diagnostics on chest X-ray, CT, ground glass opacities, widespread pulmonary infiltrates, discharged from a long stay in hospital with a residual fibrosis on home O2. He self-discharged. Eventually, he was strong enough to come to our outpatient program, but he still had global weakness, fatigue that was, I suspect, largely due to, of course, the deconditioning after the hospital. Significant musculoskeletal impairments. And so this picture to me really looked like that post-ICU syndrome, somewhat of what I expected, although it was a very severe case. Our respirologist commented that this client was probably as close to the brink of death from COVID that you could possibly be. Over time, he made significant improvements, with active rehab, with exercise-based rehab, exercise prescription. He actually returned to work on a graduated program and continues with, they continue with private PT. To compare to the second case we had, it was a client in their 30s. They presented to the ER, but they were not hospitalized. They were sent to recover at home. No cardiac or respiratory diagnostic findings, and like Katie's case, they ran through a battery of tests. He had pre-existing chronic pain. I assessed breathing pattern disorder, hyperventilation syndrome, widespread symptoms. You can see them there. Huge anxiety, depression, a huge trauma response from going through this ordeal, largely isolated. This was the first client I noted something is not right here with the fatigue. It's disproportional, brain fog, and the outcome there was, unlike our first client, this client was unable to return to work. And he was referred for psychophysiological follow-up afterwards because of the impacts of his physical sequelae. This is just a quick graph here, just showing the proportion of our referrals. So we've had 134 post-COVID referrals since December 2020. They've slowed down a little bit recently, out of 407 all-cause referrals. So that represents about 33% of our referral volume. You can see a large portion were actually clients who did not need hospitalization, and it's about 50-50 between that, we call it that phenotype, that's more multisystemic, long COVID, chronic fatigue syndrome perhaps, and then those with lung pathology that come through pulmonary rehab. So about a 50-50 split there. So the World Health Organization, thanks largely in part to the advocacy of clients and clients who are also experienced long COVID themselves, patients who experience long COVID, are starting to develop sort of a framework. They're using the term post-COVID conditions. And so under this, it demonstrates the heterogeneity of the type of patients we're seeing. This is not just one condition. This is a very descriptive sort of term. So we have first our polysymptomatic or mild, not hospitalized group of patients. And then our moderate to severe illness, hospitalized or requiring critical care. So it's sort of these two sort of groups under the same umbrella. However, the sequela can overlap here. So I've been especially talking to a lot of the inpatient physiotherapists working with clients in hospital, and they are noticing as well, even with the severe clients, dysautonomia, post-viral fatigue, patients taking a long time to rehab and discharge from hospital. We're also seeing that with hospitalized as well. And then there's sequela involving all-cause hospitalization, of course, the deconditioning, cognition, ADLs, and then sequela that's commonly observed in critical care illness survivors. So that could be the post-ICU syndrome, and of course, significant organ damage. And I just want to highlight that the organ damage is not just in this group alone, but it can also be with folks who are non-hospitalized as well. Even though there's a lot of still research to do over post-COVID conditions, we know there are known serious diagnosis associated with organ damage. And this is just a list, I won't read through them. But we know that the virus can have direct effects on the ACE2 receptor in the body. So whichever organs have that, there could be direct effects of the virus or an immune response or change in how the receptors work and things like that. I won't go into it, but and this can even be in the absence of severe infection. So back to what did we do? So when we realized, like others were globally and in the country as well, allied health, that we had to shift our perspective from what I was used to, what we were used to. We had to take on a completely new patient approach. So what are some of the steps we took in order to do that? Well, the first, with anything new that emerges, and I can't stress this enough, and this is really the thematic approach to this entire presentation, having Katie graciously speak and share her story, is we need to listen to the patient's lived experience. And I think sometimes when we have a tendency, when confronted with something that we don't understand, or is that subclinical, perhaps, are we not detecting something with our diagnostic testing? We have a tendency to be dismissive almost, maybe not intentionally, but unintentionally reduce the patient's experience to anxiety. And I think, unfortunately, this is especially true for women. And there's also a stigma to fatigue and fatiguing illnesses because it's not always visible. We need to hold space for our clients and, maybe sit with the thought for a second that Katie's story could have been any one of us. And perhaps, colleagues where they have a similar story. It could have been my story, my colleague's story, or anyone listening right now. And we need to extend patients the same radical empathy and allyship that you would perhaps hope for yourself, and move beyond just walking in their shoes, but take action to improve their situation and perhaps improve the healthcare system. The second thing I did was recruit help, and I knew immediately, especially with the neurocognitive symptoms the clients were experiencing, that I needed occupational therapists, my cousin profession, of course. And so our managers were super responsive here at Deer Lodge, and they loaned us Marlee to come over and help. And I thought initially she'll just do a few consults for us while she's turned into one of the most passionate advocates for long COVID that I know of. So I'm fortunate to know her and fortunate to have her on our team. And it's not just limited to OT. There is a role here for most allied health professions that you can think of, and I don't have time to name them all. What else? Learn from medical experts and allied health experts and folks who are already diving into this work. And here is a great resource of a lot of these folks experience long COVID themselves in their line of work. And social media was great for this. Twitter, podcasts, webinars, Instagram, you name it. It made it easier to access that in real time. Another thing we did was try to learn for similar conditions, specifically ME/CFS. Marlee will touch on that. Dysautonomia, where there's decades of research, not enough research done, of course, and hopefully there'll be more now that everyone's, this is experienced on a mass scale and this research is ongoing. It was out there. And then lastly, with almost fervent obsessiveness, which I kind of do when I don't know what I'm doing, right, is we compiled and organized resources, tools were emerging. We had to change our outcome measures, or look to experts at U of M, actually, and HSC, which helped us with that. So I was grateful for that. But also patient education. The clients needed self-management education that we didn't have done or prepared. So where were we getting this? So we had colleagues asking us, like, you guys are seeing people, as this word got out, like, what do you have for us? Can you send? We put this all together in a Google Drive so that it was easily accessible. These are just some of the organizations that were my lifeline at the beginning. Long COVID Physio was my first lifeline, even before the larger health organizations in the world caught on to the patient story. This was led by a physio with long COVID, Darren Brown. The Bradclif training helped me better assess and treat breathing pattern disorders. We have the Workwell Foundation, research in MECFS, Dysautonomia International, a huge library of webinars to learn from. And then also learning from established long COVID rehab programs that, because they were farther, like earlier in the pandemic, we could see, I was like, what are your protocols? What are you doing? What's working? What's not? What's beneficial? What's harmful? So that was Mount Sinai in New York, their autonomic conditioning therapy program. And of course, Johns Hopkins had a wonderful booklet with a strong focus. All of these were focused on symptom-guided conservative approaches with a strong focus on breathing. Here's just a few. The OT organizations, of course, Marlee looked to them. World Physio eventually caught up with long COVID Physio. They work collaboratively together. And then the bigger organizations here. And I'll just say, by the way, CDC has an excellent evidence-based information on MECFS, which Marlee's going to talk about in a sec here. So with that, I will hand it over to her to describe a little bit more of the symptoms and the conditions similar to post-COVID.
Thank you, Dana. I'm Marlee. I'm an occupational therapist at Deer Lodge Center. I work in the motor neuron disease clinic, day hospital, and I've also been working through PRP with long COVID clients. And just like Dana said, I'm not an expert on this either, and have also worked through some of my own realizations while working with people that have long COVID. So what we came to realize is that what was being seen and reported globally was also what we were seeing in practice. So results from Davis and colleagues found that systemic and neurological symptoms were most likely to persist at 6 months. And the most common symptoms were fatigue, cognitive dysfunction, and post-exertional malaise, which is worsening of symptoms even after minor exertion. This study also found for people experiencing brain fog, 67.5% required reduced work hours or were unable to work due to their illness, and 86.2% reported it mildly to severely impacted their work. This is a systematic review by Lopez Leon and colleagues, which shows over 50 effects were found with people with long COVID. Katie still has 18 symptoms on this list to date. Fatigue, as you can see, is at the top of this list. Now we're going to talk a little bit further about fatigue. We came across this quote in an article by Tooney and colleagues about fatigue that said, difficult for patients to articulate, easy for healthcare providers to dismiss. This is a common theme with clients we are seeing, saying that some healthcare providers weren't understanding their symptoms or didn't know where to send them. Fatigue levels can range from mild to severe, even in clients who had mild initial illness. Any process in the body, whether it's physical, cognitive, or emotional, can contribute to energy expenditure. So for example, if a client comes to see Dana and I for a therapy appointment, we're really keeping in mind kind of that energy envelope that people have. Another example could be that someone's stressed from a fight that they had with family or friends. These are different fatigue patterns that we're commonly seeing with the clients that we work with. So the boom and bust pattern being the most common, that people are trying to do as much as they can on days they feel well, but then they're overdoing it and in turn end up crashing and needing several days of rest. What we're trying to aim for with our clients is task modification and I really talk about with them, and so does Dana as well, how all the different factors can play a part into their fatigue pattern. Post-exertion system exacerbation or post-exertional malaise is triggering or worsening of symptoms following physiological stress or cognitive activity. A lot of clients that we work with have described this as feeling like they have COVID again. This typically occurs 12 to 48 hours after activity and can last for days or even weeks. Myalgic encephalomyelitis chronic fatigue syndrome is a complex and debilitating syndrome that must be present for at least 6 months for clinical diagnosis. Clients must have fatigue, PEM, and unrefreshing sleep, and one of impaired memory or concentration or orthostatic intolerance. Suspected causes are infection, immune system changes, stress, and changes in energy production. Studies have demonstrated a lower anaerobic threshold in clients with ME/CFS, suggesting impaired aerobic energy metabolism. For some people, even activities of daily living can trigger PEM. Any recommendations should take into account the client's energy envelope. Inactivity can also result in muscle deconditioning. As healthcare providers, we should individualize a threshold level of activity for each client. Heart rate monitoring can be used to avoid going over anaerobic threshold, and activity monitors to avoid overexertion. This condition has a neurobiological basis, and clients with this condition, as Dana previously mentioned, are often stigmatized. So as healthcare providers, we should really be aware of that. Some interventions that we're using for ME/CFS may include changes to roles and routines, self-pacing, self-monitoring strategies, symptom rating scales, and symptom tracking. It is important to recognize that clients may not fully recover from the ME/CFS during their time with us. Clinicians should promote self-management early on in the treatment process to empower clients and facilitate smooth transitions of care. This is an example of an activity log that many of our clients have found helpful. They record how much they're sleeping. Many of them have disturbed sleep patterns, how much they're able to rest throughout the day, what the activities are that they're doing each day, and then the symptoms and severity. They found it helpful because then they can kind of go back and see why they may have experienced that crash pattern and then try to modify that for the future. Now we're going to talk about brain fog and cognitive impairment. Currently available research shows that COVID long haulers may experience issues with executive function, memory, and psychiatric difficulties both during and after acute infection. And this is even for people that were never hospitalized. We are mainly seeing cognitive deficits in memory, attention and concentration, word finding, and problem solving and decision making. We've sought out speech language pathology involvement as well to help with people's cognitive concerns.
So like Marlee mentioned, one of the main things that I've struggled with post-COVID is brain fog. And so what this actually looks like is wide-ranging and never the same. A few things that have been somewhat consistent include I regularly misplace items within my home, within my office. I regularly am losing things and find them in the strangest places. I lost the peanut butter while making breakfast one morning and I found it in the sink. The number of times that I've made coffee without putting like the mug underneath the coffee maker is quite astounding. When I was first recovering from COVID, I actually didn't drive. I found it one of the hardest things for me, and I simply refused to drive for a period of time just because I found the cognitive demands and kind of the executive functioning piece far exceeded where I was at that point in my recovery. I think there's huge implications here for driving and post-COVID, and certainly that has huge implications for us as rehab professionals. I also struggled with word finding difficulties. This one was a real struggle for me in my job and really affected me when I returned to work. So I often felt like I couldn't quite find the right word to describe something or couldn't really remember the word for a certain object at all. So the phrase, "oh, you know what I mean," was quickly adopted as sort of one of my most frequently used phrases. So I'm now going to pass it back to Marlee to discuss the psychophysiological effects.
Yeah, so now we're going to talk a little bit about the psychophysiological effects that come from long COVID. This is a really great video that Dana and I both found really helpful. Unfortunately, we won't have time to watch it today as it's about 20 minutes long, but we do have the link here for anyone interested to watch it at a later time. Tiquette and colleagues found that 1 in 5 COVID-19 survivors is diagnosed with a mental illness despite having no previous mental health concerns. The virus has direct impacts on the brain and or the immune response in the brain can have psychiatric effects. Validation has been huge for people coming to see us. I'm now going to pass it back over to Dana.
Thanks, Marlee. And of course, in this day and age, you can't discuss psychological effects without also discussing physiology. In the interest of time, I can't spend too much time on the next two slides. We'll be doing a talk later in November for the Manitoba Thoracic Society, where I'll dive a little bit more into sort of from a PT perspective, some of these conditions. But dysautonomia is sort of one of the conditions that's been discussed as being similar to post-COVID. Just bring these up here. It's really an umbrella term. It's not a specific diagnosis, right? So, where we have specialists in the heart and the brain and the lungs, when we're talking about the autonomic nervous system as an organ, it's really like a complex Cisco network of computers. Like you can see all the connections here. It's highly regulated sort of in the brain, but with all these sort of feedback points. So you get one sort of effect in one part of the system, and it can have sort of a cascade effect throughout other parts of the system. So that's where a lot of the variable symptoms come in. Orthostatic intolerance. POTS is sort of a condition where we see tachycardia with position change in the absence of that hypotension, but a lot of clients with dizziness upon standing, dizziness going from lying to standing up, that kind of thing. So that changed our practice. So we had to do testing to we call it a 10-minute stand test in the upright position to assess for orthostatic hypotension as well as tachycardia within that time. Breathing is also intimately linked, of course, to the nervous system, and breathing is one of the most important behaviors we can do that acts like a remote control for our sympathetic and parasympathetic nervous system. So what I was seeing with breathing with clients, of course, is that it seemed like the system, our parasympathetic and sympathetic nervous system must be able to transition back and forth in homeostasis in order to adapt to the environment. And we saw a lot of indications that wasn't the case for people in long COVID. And we can kind of see that in heart rate variability. The higher the variability, the more your system can shut off and relax and shift back into that rest and digest response. So I found it key, especially even if I didn't understand everything that was going on with the symptoms presenting, but educating your clients on the physiology of their ANS, their autonomic nervous system, is key. And even just a simple description of the two systems. Dyspnea, I want to let Katie talk a little bit more about dyspnea because this is one of the big symptoms. And dyspnea is not just, I'm breathless going up the stairs. Dyspnea is complex. It's a disproportionate breathlessness to what you would expect. It's highly tied to, the inputs of the amygdala, stress, trauma, anxiety response. It's experienced different by different clients, and it can be debilitating even in the absence of pathology of the lungs, heart, or other systems that influence. So assessment of breathing pattern disorders or dysfunctional breathing is crucial because often you can give clients some self-management tips to take control of their breathing rather than letting it take control of them. I'll just hand it over to Katie.
Thanks, Dana. So breathlessness, shortness of breath, that's been one of my main symptoms from day one. So during my acute illness, I couldn't stand for more than 30 seconds at a time. I could not speak in full sentences. I couldn't walk even a few steps across the room. That resulted in a tremendous shortness of breath. And again, this is coming from a place of function pre-illness where I was doing CrossFit workouts 3 to 5 times a week. So this was a radical change for me and certainly not proportionate to the exertion that I was doing. So ongoing, this is still happening every day. So I constantly have a feeling of restricted breathing through my midline. I have significant chest pain. I still feel the original COVID spot is what I call it, though they've not been able to detect what that is. My physiotherapist, Dana, identified that I too have a dysfunctional breathing pattern, including significant hyperventilation. So I have been participating in pulmonary rehab. I've also found intercostal and diaphragm massages by a registered massage therapist to be really helpful. And related to this persistent shortness of breath, I struggle with significant fatigue, tense muscles, exercise intolerance, chest pain, and heart palpitations. So I'm going to pass it back to Dana to talk about a safe rehab approach.
And just to sort of get towards the end here, as a rehab is going to continue, research into rehab for long COVID is going to continue to emerge, get probably more detailed, have more of a robust outcome framework that will reach for eagerly once that all emerges. But for now, there is this document, Safe Approach to Rehabilitation. And because I think of the risk of organ damage, the risk of PEM, of all of this, a safe approach should really be our focus, of course, right? So the World Physiotherapy, recommends screening for post-exertion symptom exacerbation. We have tools in order to do that they've used in ME/CFS. Exclude cardiac impairment, communicate back to the primary care provider. If you're, seeing red flags on assessment, of course, monitor oxygen saturation. Desaturation can occur even if people aren't dyspneic, or even if they never presented with any lung impairment. Possibly, it's always good to be monitoring other vitals as well. And then, of course, screening for the nervous system dysfunction, especially orthostatic intolerance and POTS. This is just some of the existing programs that exist, here in Winnipeg. And primary and specialist care, certainly, of specialist care. The approach should be multidisciplinary, of course, because this is a symptomatic impairment, right? Primary care providers are still learning, and everyone is, eager and, excited. The primary care groups are meeting, CORS groups are meeting, like all sorts of groups are meeting, wanting to learn about, how we're going to approach this. The day hospital program does take long COVID for individuals over the age of 60. Pulmonary rehab is, like I was saying, primarily for people with lung impairment, and we've since sort of modified our criteria given the new information we've learned about long COVID. And how it presents. But, like I said, dyspnea and shortness of breath can be so debilitating, and it's not just a story about what's happening in the lungs. It's really a whole body, full system symptom. So we've been, kind of helping to redirect or figure out where we can best serve these clients or what programs. There is also the Easy Street program. I should mention I was given 2 OT students who did a lot of these interviews for us and the region learning about this. Therapists OT at Easy Street have been seeing clients. But really the overall recommendation is really sort of a one-stop shop approach, right? Both medical wise and rehabilitation approach. And there's also a private practice options, and people in the physiotherapists and other programs, the Wellness Institute in the community. Of course, we have to consider the intersectionality of various barriers to access. Most of these resources are in Winnipeg. So clients who live rurally in northern communities, perhaps in different socioeconomic groups, don't have the same ability to access some of these services.
So we just have a couple slides left, wanting to try to leave some time for questions if we can. One of the things we felt was important is sharing the patient experience of the major gaps in care. So as Dana and Marlee mentioned, I had numerous challenges in accessing care. There's been numerous changes over time in terms of eligibility criteria, access to care, lots of wait lists. There's lots of difficulties in establishing linkages between one system and the next, because unfortunately they are not communicating well together. And there's a huge role for primary care and multidisciplinary teams. I've been blessed to have a wonderful primary care doc, and she's been really, really helpful in helping me navigate the system. There's also issues in timely access to needed rehab and diagnostic services. So I just got my pulmonary function test a couple of weeks ago, and that was ordered in February. There's also challenges with lack of psychosocial support, as well as needing to advocate for higher level coordinated responses from both health and government. So when I think about this, I kind of think about Plinko, which is the beloved game from Price is Right. You kind of don't know where you're going to end up and you don't really know how, but you hope you kind of get lucky. In more sophisticated terms, Rushworth and her colleagues looked at this phenomenon, and they actually learned from the people that they interviewed that people did consider it random, a lottery of sorts, and luck in navigating services. So long COVID is even newer than COVID. And one of the questions I'd like each of us to reflect on is, are we, and I'll include myself in this, as healthcare professionals learning from our patients? There's a huge need for individual patient advocacy. As Dana mentioned, one of the challenges is patients, myself included, being invalidated or dismissed by healthcare professionals. So I had a specialist tell me, and this is a quote, "I have many patients who would kill to have your level of function." There's also a huge role for advocacy within systems. So that includes workers' compensation, health benefits, EIA, as well as the federal COVID benefit system. There's also, unfortunately, a bit of an onus put on the patient to follow up. And because each of these systems operates unfortunately, in a bit of a silo, needing as the patient to coordinate your own follow-up and follow up on test results and make sure those results go to the right people. So all hope is not lost. I'm going to pass it to Dana for just a brief mention of a couple of recommendations before we wrap up.
Yeah, I won't stick too long on this. Obviously, you can check it out in the references, but they just recommended, this was a Delphi study of primary care doctors in the UK. Long COVID clinics should operate as part of an integrated care system, holistic care pathways, investigations of specific complications, management of potential symptom clusters, and tailored rehab as needed. And there's a plethora of recommendations of various disciplines. Is very interesting to read through.
So the big question that I'm asked is, are you better yet? So as of today, I counted this, 290 days since I got COVID. So I'm still an active patient in the pulmonary rehab program. I have huge experiences of post-exertional malaise. I likely meet criteria for chronic fatigue syndrome. Lots of breathlessness, as I talked about. Lots of these I've already mentioned. I am starting to resume some of my small business operations. I'm unable to exercise, which has been a huge hit to sort of my day-to-day function. And I did receive both COVID vaccines, so I am considered fully vaccinated. So where to next? I'm still waiting on my Holter monitor and my pulmonary function tests. I am looking into the private pulmonary physiotherapy. There's a cardiology referral pending through my primary care doc. It's unknown if I will continue to have post-COVID clinic follow-up, as I was told that if those Holter monitor and pulmonary function tests come back normal, that I likely won't be seen for further follow-up. So there's a huge role for other allied health professionals, and my goals, if I can give anything through my own experiences, that's become my primary goal at this point. So I wanted to leave you with this quote. Again, this is from Rushworth and her colleagues. So all of these narratives were characterized by disrupted chronology. The trajectory of recovery in which they had been led to believe was unexpectedly upset. And given the uncertain prognosis, there was no indication of when it would be restored. There is desire, effort, and anticipation towards a recovered future state, repeatedly dashed by lack of improvement, setbacks, or the retrospective realization that recovery has not yet even begun. So on that dramatic note, these were our learning objectives today. You can read them at your leisure. We wanted to acknowledge there is a short, apparently 3-question survey available by either clicking this link or scanning the QR code. We have a number of references as well that we've cited sort of throughout our presentation. And we wanted to open it up for questions. We still have a few minutes left. So thank you all for coming, and we'll open up to questions.
Thanks so much, Marlee, Dana, and Katie. I just wanted to let everyone know that this survey is for the purposes of course, as we try to learn how we're doing with meeting people's learning needs through the Illuminate presentations. So we'd appreciate it if you do that survey. Someone would like the link in the chat. I'll see if I can figure out how to do that. There's a question about nutrition, if any of you feel like you have some knowledge around nutrition, even though you're not dietitians. You're muted, Dana.
Gotcha. Thank you. Yes, a huge role for nutrition. We do on each of our pulmonary rehab teams have a dietitian. I recently met with a dietitian from our wellness team to just hear some of her expertise and all the hard work that's going on behind the scenes in nutrition services in the area of long COVID. What our OT students, the project, it was actually, some of you might have been at that talk, was to put together, there's a huge need for peer support with any new sort of clinical condition like this. And so they identified that as like self-management peer support groups that could potentially be delivered in primary care. So they met with a number of professionals to put together some modules and met with nutrition as well. So absolutely a huge role. I'm not an expert in it, but also in altered taste and smell, in balance, the approach of balance, not just cut this out or do this and that. So absolutely, I don't know if there's any dietitians in the audience there who want to say more, but huge role for nutrition. Yeah, nutrition and breathing too has an impact on breathing.
I think as well, just related to that question, because people's activity is so disrupted and they're not able to exercise, a lot of people who have post-COVID notice a significant increase in their weight gain, or like Dana said, in sort of their food preferences because of altered taste or smell. I luckily never experienced that, but there certainly is a role for both, I think, nutritionists and dietitians in addressing those complex concerns.
Yeah, I agree. And I think that the energy levels too, and people that maybe don't have someone around to help them with cooking and they're maybe struggling to even get meals prepared for themselves or nutritionist meals prepared for themselves.
The next question in the chat is around respiratory. I've lost it and I don't know the intervention. So if anyone, have you been prescribing respiratory muscle trainers?
I bought one on Amazon and showed Dana, and she said, don't use that, you're not ready. I think is what you said, Dana.
Yes, well, that I'll clarify that a bit. That must be a physio. Maybe it's Cindy out there asking. My colleague Cindy. Yes, you know, assessing MIPS and MEPS and inspiratory muscle strength is part of our assessment. And it's certainly the thing with inspiratory muscle training is you have to train the proper breathing pattern first before you start strengthening an improper breathing pattern that's less efficient. So it certainly has a role. Cindy, my colleague, who, you know, for a long time in Winnipeg, we did not have anybody who in the private sector of physio who specialized in breathing assessment and dysfunction. I think all the respirologists out there are super excited because hyperventilation syndrome, breathing pattern disorder is prevalent. Yes, there's certainly a role for that, but yes, I wouldn't recommend clients just get one off Amazon because it can be very, very difficult and has to be prescribed in the right way, certainly. So yes.
So we are at 2 minutes too, so if people need to go, we won't be offended, but I just see there's lots of kudos in the chat here, so I'm just trying to filter through it, and I just see one question about children. I don't know if any of you want to speak to what we know about children, or I could speak to that.
There is research coming out, I mean, already that has come out about long COVID and children. It hasn't been as much of a focus for myself just because I've been working with people 18 and older, but I am really concerned for children and that this could be an issue for children as well. Kara, maybe you have more to elaborate on with that.
Yeah, it is a concern, and it's a concern about capturing children as well, because less children will be hospitalized, and so less of them would have follow-up, and they do tend to have a slightly lower, but not that different proportion will have long COVID, and so that is a concern as well. And right now we don't really have services for children with long COVID. It's a larger gap than we have with adults. Yeah.
I can say also we've had some phone calls as well to our program, especially for teenagers experiencing long COVID symptoms as well.
Well, thanks again, Katie, Dana, and Marlee. And there is some questions about accessing the slides and accessing the recording. So we'll try to share that information about how to access those things through some different channels. And thanks everyone for attending. A really big attendance rate today. I hope people learned something and got to appreciate the real on the ground experience of long COVID. I really appreciated hearing about, you doing it in action and having the evidence come out, in line with what you're doing. What a very, very eye-opening. Thanks so much. Take care, everybody.
Thank you.
Thanks, everyone.
Thank you.